Hello, welcome to today's ASPC CardioCore lecture series. My name is Alison Bailey. I'm Vice Chair of the Department of Cardiology and Chief of Non-Invasive Cardiology at the Heart and Vascular Institute at West Virginia University. Thank you for joining us for today's CardioCore. We're going to be talking about triglycerides, remnant cholesterol, and cardiovascular risk. It's my absolute pleasure to introduce today's speaker, Dr. Michael Miller. Dr. Miller is a cardiologist at Penn Medicine and a nationally recognized expert in preventive cardiology. His clinical practice focuses on preventing heart disease through cardiovascular risk assessment, lipid management, including cholesterol and triglycerides, and lifestyle modification. He also serves as a lecturer in the Perelman School of Medicine's Foundations of Culinary Medicine program, where he teaches the important role of nutrition and cardiovascular health. In addition to his clinical and educational work, Dr. Miller has conducted extensive research on the effects of diet and emotional health on inflammation and vascular function, and has authored numerous publications in these areas. He's also the author of Heal Your Heart and co-author of the American Medical Association Guide to Preventing and Treating Heart Disease and the Practice of Coronary Disease Prevention. We're delighted to have Dr. Miller with us today to share his expertise on this very important topic of the role of triglycerides and remnant cholesterol in cardiovascular risk. Please join me in giving a warm welcome to Dr. Michael Miller.
Good day, everyone. It's great to be here and to discuss a very exciting topic in cardio care, and that is high triglycerides, remnant, and cardiovascular disease risk. I'm Mike Miller over at the University of Pennsylvania, as well as the Corporal Michael J. Crescent's VA Medical Center in Philadelphia. And I also wanted to thank in advance my co-moderator, Dr. Alison Bailey. And so the first slide, I think, kind of gives you the overall 30,000-foot view of where triglycerides stand, whether you're looking at Copenhagen or looking at the States or looking at other societies. And that is, we expect in the bell-shaped curve, average cholesterol levels somewhere in the 120 to 150 range. The median triglyceride hasn't really changed that much. It's somewhere in the 120s. But as you see towards the tail end of the curve, when you're getting to 400 or 500, a lower percentage of the population, but certainly those that may be at higher overall cardiometabolic risk. So in examining the spectrum of hypertriglyceridemia and some of the metabolic implications, I like to kind of consider two different levels or range of levels of triglycerides. The first is those that increase the risk of cardiovascular disease and some of the cardiometabolic related problems, and that is triglyceride range somewhere between 100 and 1,000, give or take, with levels above 1,000 increasing the risk of pancreatitis. Now, we've appreciated for quite some time that the lower the triglyceride, the lower the risk, not only of cardiovascular disease, but also the associated cardiometabolic complications. So on the left on this slide is the BIP study, a long-ranging trial, an observational trial, and as you can see here, the lowest level of risk are those that had triglyceride levels somewhere below 100, and then as you start to exceed risk, as you exceed levels, then risk, of course, increases, and even levels as low as 100 to 149 raised risk of about 6% compared to the levels below 100, and clearly, as you increase in levels of triglyceride, that risk does magnify. So even at levels above 500, you see a 68% likelihood of all-cause mortality. If we look to the right, this is from the Baltimore coronary observational long-term study. It was a Hopkins study. And looking here again, the lowest likelihood of recurrent cardiovascular events in patients with who had undergone coronary arteriography was obtained in those patients that had the lowest triglyceride levels. Again, looking at quartiles, it was less than 100. And those at higher levels, of course, conferred elevated risk. So the way one might think about the triglyceride metabolism and cardiovascular metabolic risk is to look at different types of conditions. And I think triglyceride levels will give you a barometer of where your patient's risk might reside, such that let's take those patients of yours that have a triglyceride of less than 100. What that basically tells us is that they have an efficient way to break down fat. So they consume dietary fat. The fat is processed and out into the circulation are chylomicrons. Those chylomicrons are avidly hydrolyzed by lipoprotein lipase, resulting in free fatty acids that could be used as an energy source or stored. And then you have the resulting chylomicron remnants. Those remnants are taken up by the liver with the output of VLDL, and then that VLDL triglycerides are hydrolyzed again by lipoprotein lipase, hepatic triglyceride lipase, and it's a pretty good, efficient system to break down fat. So again, a patient of yours who has a triglyceride of less than 100 is basically telling you that they can efficiently clear fat. The problem tends to reside over time in your patients that have higher triglyceride levels. So a patient that has a triglyceride of 200, we would consider that supraphysiologic. And that, again, while the process starts off very similarly, so that you have lipoprotein lipase hydrolyzing those triglyceride-rich particles, what you end up with are more of these remnants that are circulating, and some of them may, in fact, enter into the vascular wall. And so remnants promote the uptake into vascular wall. You also have overproduction here of VLDL, and that will lead to other remnant particles, IDL, VLDL remnants, and they can also be taken up by the vascular wall. There's also perhaps amount of apoC-III containing particles, and that also promotes its uptake by vascular wall macrophages. And finally, small dense LDL, again, a byproduct through this catabolic cascade, can enhance the uptake into the vascular wall. So triglycerides above 200 tells you that your patients are not breaking down fat normally, and some of that byproducts, which are cholesterol-enriched particles, can be taken up into macrophages. And so to put this in perspective, we're looking at remnant cholesterol. The lower the triglyceride, the less of these remnants circulating, and more of them are going to be taken up into the liver and not wreak havoc on our metabolic in the metabolic cascade. As triglycerides increase, then you have more of these remnant particles, and a greater likelihood that that those cholesterol-enriched particles can be taken up into the vascular wall. And this slide just shows you very nicely that in incubating these chylomicron remnant-like particles can cause atherosclerosis. So you lipid accumulation of these macrophages in an unregulated manner. Remember, LDL has to be modified. Chylomicron remnants do not. They could just be taken up very avidly in an unregulated manner. So this slide puts into perspective the importance of apoC-III, especially if there's a deficiency. So here's a genetic deficiency identified in the Amish of apoC-III, a loss of function mutation that caused very low triglyceride levels associated with low coronary calcium. And what we also found in these patients was that when we gave them a high fat challenge, they also had lower levels of postprandial triglyceride. Remember, there is an important correlation between one's fasting triglyceride and the postprandial surge in response to a fat challenge. And you see here in the non-carriers, they had greater excursion of triglyceride compared to low levels. And what we believe happens in the postprandial state is that when you have this postprandial surge, that could also lead to the development of more remnant particles that can ultimately be taken up by macrophages. And clearly, we spend most of our day in the postprandial, post-absorptive state, as opposed to the fasting state. So this, again, the higher the fasting triglyceride, the greater the likelihood in these patients or these individuals that were protected because owing to a mutation in apoC-III, they had much lower excursion of fat, postprandial fat. And so what we've come to appreciate is that this genetic condition that lowers apoC-III is cardioprotective. And so lower triglyceride levels, lower postprandial fat, lower coronary calcium, and also lower risk of cardiovascular disease. So when thinking about the cardiometabolic consequences of hypertriglyceridemia, it stands to reason that, as pointed out already, that if you have lots of the circulating triglyceride-rich particles, they are again catabolized to cholesterol-enriched byproducts, and these cholesterol-enriched byproducts can lead to uptake by macrophages and get into the arterial wall and cause atherosclerosis. We also know that lots of circulating free fatty acids in a hypertriglyceridemic state will lead to basically fat causing enhanced lipolysis, increased visceral fat, increasing free fatty acids towards the liver, and over time can lead to lipid accumulation, hepatic steatosis. And also fat in the muscle can enhance a reduction in insulin sensitivity and promotion of insulin resistance and diabetes. And so we see cardiovascular disease, insulin resistance, diabetes, metabolic dysfunction, associated steatohepatitis, and pancreatitis that can result, as you will see. And so looking at the spectrum of hypertriglyceridemia, we're starting off with run-of-the-mill hypertriglyceridemia to about 500, then severe hypertriglyceridemia, somewhere between 500 and, let's say, 800 or so, or 1,000. If you're looking at millimoles per liter, we often will look at about 885 milligrams to the equivalent of 10 millimoles per liter, and then much higher levels can result in either polygenic or multifactorial chylomicroanemic syndrome. So the genetic factors that contribute to elevated levels of these triglyceride-rich lipoproteins, as we come to the right side of the curve here, we're looking at very high triglyceride levels, commonly exceeding a non-fasting level of millimoles per liter, somewhere in 5 range and higher, and especially when it gets up to 10, which is the equivalent of about 880 milligrams per deciliter, you're looking at chylomicronemia and enhanced pancreatitis risk. And so you're falling to the categories first of multigenic MCS versus familial chylomicroanemic syndrome, which is fortunately a low percentage of the population, but these individuals, even if it's 1 in 1,000, are at high risk of some major metabolic abnormalities that include, of course, pancreatitis. And so with respect to hypertriglyceridemia and cardiovascular risk, again, the lowest risk is somewhere, a fasting level somewhere below 100, and then that risk starts to increase, especially as we get above levels of greater than 200, and then even levels of, into the 500 to 800 range, you really have the highest risk. Above 800, you start, you're beyond the peak, but risk is certainly greater than at levels below 200. And our biggest concern at really high levels, like above 800 to 1,000 range, is the fact that you have pancreatic lipase, which is released and will take these chylomicrons and break them down to fatty acids that could promote inflammation, necrosis of acinar cells, impairment in pancreatic capillary blood flow, ischemia, acidosis, and a marked pancreatitis. And as you know, acute pancreatitis does have worse outcomes. What you may not appreciate is that if you look at patients that have hypertriglyceridemia with acute pancreatitis compared to acute pancreatitis in the absence of hypertriglyceridemia, so let's say gallbladder-induced pancreatitis, that the likelihood of an adverse outcome is much higher in those that have acute pancreatitis as a result of marked hypertriglyceridemia. So that's both organ failure, intensive care, mortality, and pancreatic necrosis. Now, in the 2026 guideline of the management of dyslipidemia, focusing specifically on hypertriglyceridemia, we're going to look at our patients that have established disease with hypertriglyceridemia. They may not have established disease, but they have risk factors, notably diabetes, or they may have neither of those, as just pure hypertriglyceridemia. And those, of course, that have more severe hypertriglyceridemic states. We're always going to first factor in evaluating and managing the secondary causes of hypertriglyceridemia, and then work towards diet and lifestyle modifications. And then we're going to, beyond that, if they still have a fasting hypertriglyceridemia, despite some of the measures we take, then other interventions that we will consider is referral to a registered dietitian nutritionist. Actually, we kind of get that earlier in this process, but clearly with persistent hypertriglyceridemia, they need to see a nutritionist, can consider TG medication, screening for FCS, and then a lipid specialist is very reasonable here. Let's look at some of the conditions and medications that contribute to hypertriglyceridemia. They include, and a lot of these is the result of the attenuation, the activity of lipoprotein lipase. So they include those that have poorly controlled diabetes, those with kidney disease, lipodystrophy, and of course pro-inflammatory states that stimulate hypertriglyceridemia. So whether it's rheumatoid arthritis, lupus, and so forth. Sepsis, of course, will also can lead to an acute phase reactant with a hypertriglyceridemic state, free fatty acids being released. And some of our patients could have pretty significant hypertriglyceridemia. With respect to diet and lifestyle, alcohol abuse can promote this, especially with dietary fat being consumed concomitantly. And then diets that are high in saturated fat, sedentary lifestyle, et cetera, can promote this. Finally, let's not lose sight of medications that are known to contribute to hypertriglyceridemia, and they include beta blockers, bile acid resins, and steroids and estrogens. So again, honing in on the 2026 guideline on managing dyslipidemia, there are health behavior interventions. And so patients that have a triglyceride between 150 to 499, we want to reduce added sugars. We can keep their fat at a reasonable percentage. Again, if you think about the Mediterranean diet, that fat is mostly in mono or polyunsaturated fats. We want them to avoid alcohol and then be physically active. And 150 minutes a week, walking daily, walking after a meal is also really important because that can activate lipoprotein lipase. And then recommending weight loss in our patients who are overweight or obese. When triglycerides get up to the 500 to 1,000 range, again, we're going to make more restrictions with respect to added sugars, lowering fat, and then recommending abstention of alcohol. If triglycerides are greater than 1,000, we want to eliminate added sugars and abstain completely from alcohol with much lower fat. This may get us into the FCS grouping. So here are proposed therapeutic considerations. We have the 150 to 499 as a CVD phenotype. You also have a phenotype of 500 to 1,000 as CVD, but you also now get into fatty liver arena. And then, of course, greater than 1,000 is pancreatitis. And then we have treatment that has been shown to reduce risk. They include a purified EPA or icosapent ethyl that has a more modest TG lowering effect, but also reduces inflammation and likely has a benefit in reducing cardiovascular disease through this mechanism. When we get to higher triglyceride levels and fatty liver disease, we're looking at a fibroblast growth factor 21 analog, such as pegozafermin and defibrates that lower liver fat. And then when we get to levels that exceed 1,000, we're worried about pancreatitis. And we have apoC-III inhibitors that now in the States include olezarsen and plozasiran. So the guidelines in the management of dyslipidemia in our patients that have hypertriglyceridemia and have triglyceride levels between 100 to 499. Of course, we want to lower their LDL, intensify LDL lowering therapy. And if they have residual hypertriglyceridemia, then you're going to consider adding icosapent ethyl. And that is based upon the REDUCE-IT trial that showed in patients that had established cardiovascular disease or diabetes and had a triglyceride between 150 to 499, you had a 25% reduction in MACE events, major adverse cardiovascular events, and a 26% reduction in the secondary composite endpoints of cardiovascular death, MI, and stroke. And when we look at the studies that have looked at triglycerides within this range, the only therapies that have proven to be effective is purified EPA. That's icosapent ethyl in the clinical trials, and there are 3 different clinical trials that have shown benefit. And then if you look at a combination of EPA, DHA, did not get the same result. And if you look at fibrates, also did not got a negative result. One thing to keep in mind is that these trials, the randomized clinical trials, have focused in on triglycerides of 150 to 500. But again, as I pointed out, risk continues to increase to about 800, and we just don't really have clinical trial data here at this point in time. So just remember that the data that we do have in cardiovascular risk that specifically shows benefit with icosapent ethyl or purified EPA is at these levels here, 150 to about 500, actually all the way down to 135. What about if levels are now above 500? We already talked about, again, these are from the new guidelines. We've talked about secondary causes. We want to optimize diet, activity, restrict alcohol or eliminate alcohol, weight management. And then if they have persistent hypertriglyceridemia, you could estimate their overall risk. You want to drive LDL levels down, of course. You have an optional ApoB goal. And then we got to want to try to lower triglycerides with fibric acid derivatives, omega-3, fatty acids to lower triglycerides. When we get to higher levels, familial chylomicronemic syndrome and fasting levels that are at least 1,000, going to recommend a dietitian, a lipid specialist. You can add a fibric acid derivative, an omega-3, but if they truly have FCS, then you really want to consider a class 1 indication is to consider apoC-III inhibitor, and it's olezarsen for reasons that I will shortly show you. So we've already talked about levels between 150 to 499. Now let's talk about fatty liver and pancreatitis and those treatments and the data supporting them. And this is the data that looked at pegozafermin, the FGF21 analog, and showed reduction in liver fat over a relatively short time frame. So something that now to consider in patients are other mechanisms to reduce liver fat. Fibrates also appear to have this benefit. Pancreatitis, this has really been an enigma for many years because we really haven't had good therapies, powerful therapies, robust therapies that we've been able to show reduction in pancreatitis until recently. And so olezarsen has now been shown to reduce pancreatitis, and in fact, an 85% reduction in acute pancreatitis in 2 trials using the combined doses of 80 milligrams compared to placebo in our patients with marked hypertriglyceridemia, and olezarsen with TG levels of exceeding 880, and a history of acute pancreatitis had marked reduction in episodes. So with the number needed to treat quite dramatic at 4. And then more recent data with another apoC-III inhibitor, which is a plozasiran, showing also a significant reduction in those that receive plozasiran versus placebo, coming in the first event of acute pancreatitis in patients with persistent chylomicronemia. And again, an effect here that was recently shown and very favorable. So in summary, evaluating patients with hypertriglyceridemia and those that have considered the big picture, hypertriglyceridemia that could promote cardiovascular disease. We're thinking about remnants promoting it, apoC-III are important contributors, and the range of risk of cardiovascular risk is somewhere between 100 to 1,000, although again, the clinical trials did not go all the way out to 1,000. They went up somewhere to about 500 or so. We appreciate that severe hypertriglyceridemia levels defined as a greater than 500 contributes to metabolic abnormalities, and we're thinking about MASH, and then as levels go up even higher to levels exceeding 1,000, give or take, pancreatitis. The great news is that we have novel therapies that reduce the risk associated with all the potential sequelae related to hypertriglyceridemia and cardiovascular disease, MASH, and now pancreatitis. So this is a very exciting field with many strides made just within the last 5 to 10 years. Thank you very much, and I look forward to the Q&A session.
All right. Well, Dr. Miller, thank you so much. That was a really fabulous presentation. I know I learned a lot, and I'm sure all of our viewers out here did. Before we begin today's discussion, I'd like to thank everyone for joining us and for your continued support of the American Society of Preventive Cardiology. If you're not already a member of the ASPC, we invite you to become one. Membership offers a variety of great benefits, including access to our online community, Doc Matter, exclusive member pricing for the ASPC Congress on Cardiovascular Disease Prevention, which is coming up very soon, the end of this month in Scottsdale, and member-only educational content and resources. To learn more or to become a member, please visit aspconline.org/membership. All right, so now we heard your great lecture. It was fabulous, and we've got a lot of questions from the audience. So I thought maybe we'd start with one of the easier ones first. So, according to current guidelines, in patients with severe hypertriglyceridemia or triglycerides over 1,000, should the primary treatment goal be to reduce the risk of acute pancreatitis or to reduce cardiovascular risk? And how do you prioritize therapy in clinical practice?
That's a great question. And of course, I would say, acute pancreatitis could be devastating and we know some of the sequelae associated with it. So I would work pretty feverishly to try to get the triglycerides down to reduce the risk of pancreatitis. I think as an acute, problem, that would be my goal in somebody presenting with a level that exceeds 1,000, usually about 1,000, give or take. But keep in mind that with that, only 10%, 10 to 20% of your patients that have triglyceride levels exceeding 1,000 ever develop pancreatitis. So it's still a relatively small possibility or probability, but you want to try to get those levels down, and you can really do that pretty well with both lifestyle therapies as well as medication. I've had in my practice a couple of patients who made tremendous lifestyle uh, changes and were able to reduce their triglycerides way outside the danger zone. So they were above 1,000 and got it down to well below 500.
And when you get them down to below 500, then your risk of pancreatitis goes down, as you've already talked to us about. Then what do you do? What do you focus from a cardiovascular risk at that point?
Yeah, so I think then you have to look at what other comorbidities that patient may have that may be promoting the hypertriglyceridemic state. Of course, insulin resistance and diabetes is pretty prominent among those comorbidities. And given that, then you have to determine if does that patient have pre-existing disease? Does that patient need to be on additional medications? With the new guidelines now that came out, which was great to see. I mean, I'll give a plug to to my my good friend Roger Blumenthal, who was one of my classmates during fellowship, and so he led this, and Pam Morris. It was a great group of people, and they really spent a good amount of time talking about hypertriglyceridemia, which was not the case in prior guidelines. So it's nice to see. And I think now that the guidelines do recommend some medications that in the right population that may be used in your hypertriglyceridemic patients. And I could just say if they're in the level of 150 to 500 and they fall into the reduce it range, icosapent ethyl might be a consideration. If they're over 500, then you could consider omega-3s or even fibrates in that group. And then if you're looking at patients that are at risk of pancreatitis, olezarsen now has that indication, class 1 indication to reduce that risk. So we have some great therapies that are out there.
Excellent. Well, it takes you right into one of our next questions. Our next question was, how do you decide whether to use olezarsen or you're going to have to
Plozasiran.
plozasiran. There you go.
Plozasiran. Yeah, I mean
That's
they're both super great medications, both with important papers in the New England Journal, nice effects on dramatically lowering, a great effect on TG, but also they're apoC-III inhibitors. And it turns out that apoC-III is an important player, as described in the lecture, in promoting atherosclerotic disease and also in patients that have more type of triglyceridemia to reduce their risk of pancreatitis. So how do you decide? Well, they're both approved in FCS. Plozasiran was just recently approved for FCS. Olezarsen was approved to reduce pancreatitis, has that FDA indication. I presume that plozasiran will get that indication. So, your choice, what's available is how you may want to consider it, but they're both really good therapies.
excellent. And a new tool sort of in our arsenal for this difficult to control condition.
Oh my goodness, Allison, I mean, could you remember 10, 15 years ago, we
Mhm.
had nothing because the question always came up, well, okay, my patient has triglycerides of 1,500. If I get it down, how do you know you're going to reduce the risk of pancreatitis? And we didn't have any data to support that. And now we have two studies, both in the New England Journal, that have shown that there's associated reduction in pancreatitis with either of these medications.
Excellent. All right, so this is kind of going to tie into what we were just talking about. When your triglycerides are greater than 885, is it always MCS or FCS, or can secondary causes also cause significant elevations to that level?
It's an important question, and that's why there's the so-called North American score to assess to kind of single out, try to differentiate between MCS and FCS. That was published in the Journal of Clinical Lipidology. Rob Hageley's first author. I was part of that group to kind of help to dissect out some of the different manifestations. FCS patients invariably will have a genetic abnormality, primarily in lipoprotein lipase. It's about 80 to 85% of the time, and if it's not an LPL, there'll be a defect in one of the other genes that are associated with hydrolysis of the workaholic of LPL that serves as a cofactor, whether it's apoC-II or GP1, HBP1. There are several other associated genes, but practically speaking, you could get that score, and typically an FCS patient tends not to have other comorbidities. So a patient that has MCS has a high triglyceride, often because they have some metabolic disturbances, whether it's diabetes, they may have thyroid issues, they may have kidney-related issues. And so those individuals may also have a higher BMI, comorbidities, and so there are some clues that can help distinguish that. And I would suggest you look at that score and put your patient's numbers in there, and that'll help to determine if they have FCS or multifactorial chylomicronemic syndrome.
Excellent. I think that's great. So kind of playing on the same line of questioning, when both cholesterol and triglycerides are moderately elevated, how do you distinguish between combined hyperlipidemia and familial dys-beta lipoproteinemia?
Yeah, so they're two distinct entities. So combined hyperlipidemia is the one that we are most concerned about. I mean, it's common, and it's probably the most common lipid abnormality you're going to find in our patients. Certainly before in the pre-statin era, it was by far the most common entity. So a little bit of elevated LDL, a little bit of elevated triglycerides. In the case of type 3 or dys-beta lipoproteinemia, that is a specific defect in lipoproteinase. So they have an E2 genotype, and those individuals tend to have high triglycerides. Their LDL tends to be normal or low. So they have high triglycerides and high cholesterol. They will also commonly, well, a lot of the times, have some other telltale signs. So in the so-called type 3, they could have, if you look at the palm of their hands, which I always do, by the way, two things you should do when you're examining your patients. Feel their Achilles tendon. Unless they play for the Philadelphia Eagles, where I'm from, they shouldn't have thick Achilles tendons. And if they do, then you have to consider FH, because that's where you're going to feel it, thickened Achilles tendon, or if they have some discoloration, yellow, orange streaking in the palms of their hands, that could be an indication that they have type 3 beta lipoproteinemia.
Okay, great tips, physical exam tips. I always love that. I think we don't do quite enough of that these days.
Yeah, you can also
Uh,
see some eruptive xanthomas. Now, in patients that have run-of-the-mill familial combined, telltale signs are not going to be there unless, of course, they have diabetes, and then you're looking at some other signs of diabetic patients.
Well, while we're talking about genetic instances, you brought up this Amish study in your presentation today. So one of the questions is, are there identified homozygotes with the Amish with the apoC-III loss of function mutation?
Yes, I'll go back. So that original paper was published in Science. I think it was around 2008, and it was a very interesting group because these individuals had super low triglyceride. that was identified in Lancaster. The Amish are, despite having not the best diet, right? They believe in eating milk and whole milk and cream and ice cream. But they walk on average, somewhere about 10 miles a day. They get about 20,000 steps. They are super active. They're not on their horse and buggy, they're walking. So they're
Hmm.
super active. And so the average triglyceride in an Amish individual is well below the average non-Amish American. So if you're looking at Americans, the average American runs a triglyceride level, probably the median is in the 120s range, give or take. The Amish is somewhere about 80 or so. But these individuals that had this mutation in apoC-III ran triglycerides in about 40, 50 range. So much lower, much lower. And as it turns out, as was mentioned in the lecture, these were all heterozygotes, by the way, all heterozygotes. So one defective allele that caused this dramatic effect. There have been homozygotes, not in the Amish, but homozygotes that have been reported. But clearly, the 30 to 40% reduction in triglycerides also corresponded to that amount of lowering of cardiovascular risk, not only in the Amish that had the C3, but also other loss of function mutations. And so it's clear that if you have that C3 mutation, you're in pretty good stead with respect to cardiovascular risk.
Excellent. It was interesting. I'd never heard of that study, so that was great. Let's see. So here's another question. With regards to hypertriglyceridemia and diabetes, is it fair to say that there's a bidirectional causal relationship, or is it usually insulin resistance, type 2 diabetes causing hypertriglyceridemia?
Yeah, they're kind of interdependent, LDL and triglycerides, and um, uh, but and it turns out, interestingly enough, in both ways, if you look at the relationship between triglycerides and diabetes, because we're all taught that if your patient has diabetes, then you need to watch their triglycerides because diabetics tend to offset LPL activity. And as a result of that, the impairment in LPL activity in a diabetic patient who's not well controlled can really spike up triglycerides. But it also turns out, because I've seen this in my practice, going back to Maryland many years ago, that following my patients I've followed some of these patients over 30 years, that when they were young, let's say they were in their 20s and 30s, and ran triglycerides in about the 3 to 500 range. At that time, they were healthy, right? No evidence of
Mhm.
insulin resistance. They developed diabetes over time. And a paper that was published by a group in Scandinavia actually found that if you followed triglycerides over a period of time, those individuals who had the lowest baseline triglycerides were at lowest risk of developing diabetes. So again, it points out that what your triglyceride is telling you is your ability to efficiently metabolize fat, break down fat.
Okay. So maybe a heralder of things to come as we get older if we can't handle triglycerides appropriately.
Yeah, and one thing that I tell my patients that do have some degree of hypertriglyceridemia
Mhm.
is that you shouldn't overload the system. In other words, don't have, a big fatty meal because it's going to be in your system for a much longer period of time. It's better to have small amounts of fat throughout the day than eating a large meal that contains a fair amount of fat. If your patient's triglyceride fasting level is somewhere above 150.
Okay. Well, and as somebody who's been talking about diet for a long time, we talked about your culinary medicine experience, which I love. What do you tell patients in practical terms about dietary changes to lower triglycerides?
Yeah, and again, I'll preface this by saying that you get more bang for your buck with a good diet as it relates to lowering triglycerides, where you can get upwards of 30, 40, and if you're doing exercise, maybe a 50% reduction. LDL, you generally don't see that kind of effect. You may get a 10 to 20%. Yeah, in some cases, if your patient really consumed a lot of fried foods and,
Mhm.
high cholesterol containing products, maybe they'll get a little bit more. So triglycerides, what I tell my patients is, I mean, it's saturated fat really can promote it. Fried foods can also promote it. And so go to foods that are, lower in saturated fat, whether it's monounsaturated. It turns out poly might be a little bit better than mono, but no, if you're eating the Mediterranean diet, then you're going to be also helping to lower your triglycerides. And fish, as long as it's not fried shrimp, stay away from that fried shrimp. I think they probably have some in West Virginia. In Maryland, we used to have a lot of crab, and crab is good for you, as long as you, again, don't have those deep fried crab cakes. Broil them, and it's a different story. But yes, fish is good to help to lower triglycerides.
Excellent. And alcohol? What's the advice about alcohol these days and lowering triglycerides?
Yeah, so we've known that alcohol is not your friend if you have some degree of hypertriglyceridemia, and the combination of alcohol with a fatty meal can cause
Mhm.
this alcohol-based lipemia, where triglycerides could really spike up, really dramatically go up. And it's good to see the new guidelines. The 2026 edition has specific recommendations now to either limit alcohol or abstain from alcohol. First time. So
Mhm.
that's really good news. And it also, of course, also talks about not only, making some dietary recommendations, but also doing muscle, weightlifting, weight toning can add an additional 20% lowering of cardiovascular risk. This doesn't get enough hype, and prior guidelines have not discussed it, but we've known this from the physician studies done in Boston years ago, that you get that, added bonus of doing weight toning, which in older people is great for their balance as well, right? So you don't have to be a
Right.
weightlifter, but just do muscle toning, which is really good, also protects you cardiovascular wise.
Yes, no, I think it was great. I agree with you. I think these guidelines were great. There's so much about lifestyle in there that we haven't had before. Well,
And
before
part
we
of the
move
reason
on,
too, by the way, when you do muscle toning, is you're also activating lipoprotein lipase. So you're improving insulin sensitivity in the muscles. And as such, that is also part and parcel of the big package in your recommendation for lifestyle changes.
yeah, it's one of the things that I really love about these continuous glucose monitors is, now my patients come in and they can really see what exercise does to their glucose and their insulin resistance. But, 10 squats, and it's so powerful to watch the sugar go down, like just rapidly go down, much the pathway you were just describing.
Big effect.
Before we move on to our final questions, we'd really appreciate it if you could take a moment to complete our brief survey by clicking the link in the chat. Your feedback's invaluable to us. We're really interested in improving our CardioCore lectures, and we want to know what you think and what you'd like to see. So thank you for taking your time to share your thoughts with that. We've got a couple more questions here. One of the ones I like outcomes data. So one of our questions is, what are the outcomes data for pancreatitis reduction with fibrates with severe hypertriglyceridemia?
Yeah, so I really, and this has been part of the concern in the fibrate era. We had a number of really good studies. Actually, the best studies were done with gemfibrozil back in the day. You had the VA HIT
Mhm.
study, you had the Helsinki Heart study. But with respect to pancreatitis, we really didn't have, and none of the therapies have targeted until recently, until the apoC-III inhibitors. We didn't really have good supportive data to show that fibrates would have a really beneficial effect on lowering pancreatitis. But we do have the apoC-III inhibitors, both
Mhm.
olezarsen and plozasiran, that both do it. So that would be my recommendation. If you're thinking about a patient that has a history of pancreatitis, it's one of those medications. Again, olezarsen is FDA approved for that. But if your patients have FCS, then either of those two medications come into play, not fibrates.
Excellent. And so if a patient has triglycerides less than 150, but elevated triglyceride over HDL ratio, would it make sense to treat with medications, or would you recommend just lifestyle modification?
Yeah, so if a patient has a triglyceride less than 150, the triglyceride to HDL ratio is interesting. We used to think that a low HDL is a big problem. When I got into this field, it was LDL followed by HDL, and then lowly third is triglyceride. We've now come to appreciate that HDL should be lowly third. And so we actually looked at that. We looked at this in the Framingham Offspring study. Part of the problem with comparing HDL to triglyceride was Framingham did not have triglycerides in the original cohort. They had them in the Offspring study. And we looked at this paper, my colleague Jackie Bartlett from Dartmouth, first author, that we published about 10 plus years ago now, looked at this, looked at triglycerides and HDL and the relative importance. So if you have a triglyceride to HDL ratio, high triglyceride, low HDL, it's not as important. The big picture is an isolated low HDL in of itself is not that critically or fundamentally problematic. But when you do add LDL and triglycerides to that, so if you told me the TG to HDL ratio is a problem plus LDL, then I'd say, yeah, we may consider medications for that individual. If their LDL is okay, let's say their LDL is below 100, the triglycerides less than 150 and happen to have a low HDL, I'm probably not going to get super concerned and try to work more on lifestyle.
Okay, excellent. Well, I think this is maybe a great last question. We're almost at the end of our time here, but all right, thinking genetics. With the emergence of targeted therapies, do you think identifying pathogenic variants in triglyceride metabolism genes will become essential for selecting treatments such as apoC-III or ANGPTL3 inhibitors?
Yeah, and they all have really nice effects, right? On the C3 inhibitors as well as the ANGPTL3 inhibitors also have a reasonable effects. But the question is, will you have data, supportive data, to fundamentally say one is better than the other? And so I think, as I've always thought about things simply, do the least amount to get the most information. And so for me to want to start doing genetic studies, yes, if I'm doing a research study for sure, but practically speaking, I'm not sure you're going to need to do that unless you really have evidence saying that the C3 inhibitors are so much better than the ANGPTL3 inhibitors in reducing one's risk. So until we get that information, I would say do the study. I'm not gonna start doing all genetic testing on all my patients.
Okay, very good. Well, Dr. Miller, this has been really fabulous. I think you've shared a lot of great history with us as well as the new and emerging therapies. Is there anything that you think is important that we haven't talked about in the last couple of minutes?
No, Alison, I mean, I think these are great questions. We've seen, I think, a sea change with the new guidelines in terms
Mhm.
of, not only triglycerides, but just getting to our patients at a younger age fundamentally have a difference. And we have great therapies that have just recently come out that you've heard about. We have, some great therapies that have also just come out, maybe not for triglycerides, but for lipid lowering. And so this is a moving target. It's a great area. It's a great time to be in this field.
Excellent. That was great final words. So, I'll ask you one last question, hopefully a short one. For anyone who hasn't prescribed these new therapies, any tips for getting, for like how to get access? I know access for our patients is always important with new therapies.
You have somebody who I think works with you that can learn the system for prior authorization. So we have
Mhm.
at Penn, we have that ability to help and targeted phrasing as well, smart phrases that may be used to work with your pharmacy. But it's not necessarily an easy climb to get, depending on what your patient's insurances are. But nevertheless, we're able to get uh, uh, most of our patients to therapies that are quite useful to get their lipids in normal range.
Excellent. Excellent. Well, thank you again so much. This has been really enlightening, and I know our audience has enjoyed it. And again, thank you to everyone who joined in tonight for CardioCore. We'll be back again soon. And if you can, join us in Scottsdale for the ASPC annual conference at the end of the month. Lots of good education in person and virtual. Thank you.